Good evening, everyone.
Yeah, good evening.
So, today's the topic is neurological disorders, and the speaker that we have here today is Dr. Varun Pushkarna, who is Senior Consultant in Internal Medical Fortis Escortis Hospital, Amritsar. Thank you, sir. So, you may start now.
Yeah. So we'll be discussing the EDIC neurosciences, and it is an amazing topic and almost covers around 30% of the syllabus for EDIC. So we will just first brush upon the most important topics, the key points. You can take snapshots for these because these are the mandatory ones that you need to know for the exam. So the key topics from neuroanatomy and physiology would be blood supply to the brain, taking in consideration the circle of Willis and its autoregulation. Cerebral perfusion pressure. You will have at least one or two questions from this topic, cerebral perfusion pressure, which actually is calculated with mean arterial pressure minus the intracerebral pressure, and the regulation of ICP and Monroe Kelly doctrine. We'll go into it. Brainstem reflexes and neurological examination in the ICU. Pathways in the spinal cord, both motor and sensory tracts, along with CSF production and its circulation. So these are very important topics. You should brush them very thoroughly. Then comes the neurocritical care part, in which mainly five topics are there, which are asked time and again, and no matter what stem they start with, they eventually end up discussing these topics. One is the management of intracerebral pressure in traumatic brain injury, and then the strokes. So, ischemic versus hemorrhagic, both of them, and their considerations in the critical care. Then, status epilepticus. I mean, normal seizures are not the ambit of critical care, it is the status epilepticus, its management and the drug therapy. Then, the criteria to diagnose brain death, the confirmation of it, and how to proceed about it. Then these days, a lot of questions are being asked from induced hypothermia, temperature control for neuroprotection, sedation, and of course, ventilation. So these are the core topics of the neurocritical care. Uh, Obviously, what happens is when people are preparing for EDIC, they are usually preparing more for the neurocritical part, but they're ignoring the physiology and the pharmacology. So the pharmacology is the next topic, which includes the drugs which are required and are given for sedation in a neuro ICU, including the famous drugs propofol, dexmedetomidine, and benzodiazepines. Then the anti-epileptic drugs and their use in the ICU. Then osmotic therapy like mannitol, glycerol, hypertonic saline, their use in raised ICP. Then the use of vasopressors and autoregulation in the neuro ICU. All right. So we will begin with the topics and MCQs because that is the crux where we all have to land up on. So we'll just discuss these topics, and then eventually we will venture into the clinical scenario. So we have a 55-year-old male who is admitted with a severe traumatic brain injury. His ICP is 28 millimeters of mercury and MAP is 80. So, what is the cerebral perfusion pressure and what is the target range in traumatic brain injury? Anyone? So, this is a topic of traumatic brain injury and the management of cerebral perfusion pressure. I understand you guys are preparing for EDIC, so you must be ready for a question like this. So, can anyone answer this? So, what is the CPP here? So CPP basically is, as I told you, MAP minus ICP. So MAP is 80 and minus 28. So what we get is 52 millimeters of mercury. So at least we get one of the half answer correct. That is 52 millimeters of mercury. So the Brain Trauma Foundation, that is the BTF, it has issued guidelines that recommend that a CPP should be maintained around, anyone, 60 to 70 millimeters of mercury. So this is mandatory information for all the people who are appearing in EDIC. To prevent, why do we need so much of CPP? Anyone? Why do we need a CPP of 60 to 70? So that the blood could flow through the swollen brain and nourish the cerebral areas. So as to avoid ischemic injury, and also to avoid excessive perfusion also at the same time, so that it doesn't cause unnecessary edema because of the high perfusion pressure. Everybody got this question? Yes, you can contribute, because as I
Yes.
progress, it will become an more of an interactive session and lesser of a one-sided knowledge gathering. Okay, so what have we gathered from this? Number one, that the formula for calculating CPP is MAP minus ICP. And the second is that as per the BTF guidelines, Brain Trauma Foundation, the CPP has to be kept between a narrow range of 60 to 70 mm of mercury to avoid both ischemia and excessive perfusion leading to cerebral edema. So the answer is correct. Map the 52. So this is the target CPP has to be around 60 to 70 millimeters of mercury to avoid secondary ischemia and avoid excessive perfusion that could worsen the cerebral edema. Which of the following is true regarding the blood-brain barrier? Number one, it allows large hydrophilic molecules to pass easily. Number two, it is disrupted in conditions like meningitis and stroke. Number three, it prevents passive diffusion of lipophilic drugs. And number four, it is primarily maintained by astrocytes and Schwann cells. So which of these are true for the blood-brain barrier? So blood-brain barrier is made by which type of cells? Anyone? So blood-brain barrier is basically formed by the tight junctions of endothelial cells, okay, and they are maintained by the pericytes and the astrocytes, okay. So these are the junctions which are protected by the pericytes and the astrocytes. So astrocytes is correct, but Schwann cells is not. So there has to be pericytes to make this answer correct. So that means this answer is wrong. Okay. It allows large hydrophilic molecules to pass easily, when actually it allows only lipophilic molecules to pass. So hydrophilic molecules that do not pass easily, they are passing with difficulty. So true, the good brain barrier will not allow the hydrophilic molecules to pass. And then it is disrupted in conditions like meningitis and stroke. This is correct. It prevents passive diffusion of lipophilic drugs. When I just told you that it basically is meant to allow the lipophilic drugs to pass through. So this is also wrong, that it does not prevent, is it assists. So the only correct answer we have here is it is disrupted in conditions like meningitis and stroke. So what have we gathered from this? That the typical blood-brain barrier, it is basically made in the tight junctions of endothelial cells, and it is made by astrocytes and pericytes. It does not allow hydrophilic cells molecules to pass through, but for lipophilic it allows to pass through. So the answer correct is disrupted in conditions like meningitis and stroke. So it is a selective barrier which is formed by the endothelial cells tight junctions maintained by astrocytes and pericytes. It prevents the hydrophilic molecules, but it allows the lipophilic molecules. In conditions like stroke, meningitis, and trauma, the blood-brain barrier becomes leaky, leading to vasogenic edema. Okay. A 40-year-old man with subarachnoid hemorrhage is in the ICU. Nimodipine is administered to prevent which of the following complications? Rebleeding, hydrocephalus, vasospasm, or seizures? It is a very easy question. I think everybody can answer that. So what is the answer? Yeah, so the answer is vasospasm. So basically, nimodipine is a calcium channel blocker. It is a CCB. It reduces vasospasm. And what is the most common time for vasospasm to happen?
Day 4 to day 10.
So it is most common between 3rd to 14th day post-operative. So day 3 to day 14. So nimodipine is very, very effective. Nimodipine reduces vasospasm. It is a dihydropyridine category calcium channel blocker. It reduces the risk of cerebral vasospasm that occurs usually 3 to 14 days post SAH. It does not prevent rebleeding, but improves the outcomes by enhancing the cerebral blood flow. So it is a very common question in EDIC. You need to know about that. Which of the following sedative agents is most suitable for neurocritical patients with traumatic brain injury? Midazolam, propofol, dexmedetomidine, or haloperidol? So we need a drug which helps in neuroprotection. That means it decreases the cerebral metabolic rate of oxygen. It decreases the CMRO2. It gives sedation. Should not affect the target CPP. How much is the target CPP? It is 60 to 70 millimeters of mercury. And should not accumulate in the body. Is that okay? So these are the criteria for a good sedative agent in the ICU. So midazolam is a very good agent, but the problem is that it can decrease blood pressure, it can accumulate in the body. So midazolam, although it is a very good anti-epileptic also, but it is not a preferred agent as much as is the propofol. Propofol has its own sets of problem like hemodynamic instability. Then there is a syndrome known as propofol infusion syndrome. And so although these are the problems, but still we can use. Any problems with dexmedetomidine, anyone? Can you tell me what could be the possible problems with dexmedetomidine in its use for TBI?
Sedation is not very adequate.
Okay. Anything else?
Hypotension.
Hypotension is not a major problem with dexmedetomidine, but you understand that it is an alpha 2 adrenergic agonist. So there is a major problem that, okay, BP it can lower, but it can cause bradycardia. It is known to cause bradycardia, so much so that you will not realize that if this bradycardia is because of the brain injury and cerebral edema, or it is because of the agent, the drug itself. So, the dexmedetomidine, because it decreases the mean arterial pressure, there are possibilities that it might reduce the cerebral perfusion pressure as well. Although there have been some studies which show that dexmedetomidine may cause vasodilatation, cerebral vasodilatation, and it can lead to increased ICP also. So dexmedetomidine is not a favored drug. And then yes, it does not have, as somebody said, lack of reliable sedation. Sometimes it causes too good sedation, sometimes it doesn't cause a good sedation. Then the patient may have problems when you are weaning off the patient from dexmedetomidine. It can lead to rebound hypertension. So some people can bleed and have an intracerebral hemorrhage after stopping dexmedetomidine. And because it tends to get accumulated in the body, there are chances that it can uh, accumulate and cause more problems later on. So it may be used in mild to moderate cases of traumatic brain injury, but in severe TBI, where we do not want much of the problems with the cerebral perfusion pressure, we do not want certain drugs like this. We do not want deep sedation in these patients. So the only effective answer here, it is propofol. Now, propofol is actually the preferred agent for sedation in neuro ICU, specifically for traumatic brain injury. But it has its own set of problems like PRIS. PRIS is propofol infusion syndrome. So when we are talking of PRIS, we need to understand that it is rare, but whenever the patient who has been given high dose propofol, including all patients, including the patients of TBI. So, what are the risk factors? Number one is when the propofol dose has been given more than 4 mg per kg per hour for more than 48 hours. So, this is the number one factor for PRESS. Number two is basically patients who require long-term sedation. For example, the ones who have long sedation, for example, status epilepticus. So if you give them, then there are chances that these patients may develop PRESS. And then, of course, sometimes what happens is these patients are in sepsis, and we understand that propofol is made in the fat solution. So there are chances that these patients can develop uh, fungal septicemia, and of course increased triglycerides can lead to pancreatitis, and there are so many other things. It can cause rhabdomyolysis also, propofol. But anyways, as the time, it has stood the test of time, and under less than 4 milligram per kg body weight per hour doses, it has been found to be an excellent drug to sedate the patients with, even with severe TBI. So propofol is good. Why it is beneficial? Because it allows for rapid titration. So you can increase and decrease, and the metabolism is very quick. Neuroprotection is also there because it reduces the metabolic rate of brain, its oxygen requirement. It lowers the ICP, and careful monitoring is important to avoid hypotension and propofol infusion syndrome. Midazolam has a problem with accumulation, and dexmedetomidine has a lack of ICP lowering effects. In fact, it can cause deep bradycardia, which can lead to masking of cerebral edema sometimes. A patient is diagnosed with Guillain-Barré. We will discuss all of them. I'm just brushing you up with the type of questions you can get in EDIC. Some people just fear that, oh, EDIC will have so difficult questions. No, they just have usual questions, the routine things that you do in the neuro ICU. A patient is diagnosed with GBS. What is the most appropriate first line treatment for such a patient in the ICU? High dose corticosteroids, IVIG or plasma exchange, IV cyclophosphamide, uh, or subcutaneous methotrexate. Anyone?
B.
Okay. What about A?
The extirpate is usually it's contraindicated.
Yes. So nowadays, steroids, they are not indicated at all. Although people are still giving, I don't know why, but then um, it is uh, it is not indicated any longer. So what we would like to see is that the patient is started either on IVIG or plasma exchange, plasma pheresis, or a combination of both immediately. So we understand that GBS is basically an acute immune mediated. So every word is important. Immune mediated polyradiculoneuropathy. Is that okay? So it leads to rapidly progressive symmetrical weakness plus variable sensory involvement also. Sometimes people can have tingling sensation in their legs. Plus, very less books mention it, but these patients can have ophthalmoplegia. So when you look at them and you try to see the range of motion of their eyeballs, you can find that they have ophthalmoplegia along with. What are the agents which are usually responsible? So it usually happens after some infection. Okay, so molecular mimicry or something like that is the basic root of cause. So which are the main infections that can cause it? Basically any uh, common cold like upper respiratory infection, viral. Which viruses? EBV can cause, CMV can cause, even mycoplasma pneumoniae is also included in that. And then second is GI infections, which are Campylobacter and jejuni. So these are the most common infections that can cause. So GBS per se has 3-4 types. Can anyone tell me what types of GBS is usually seen? So number one is AIDP, which is acute inflammatory demyelinating. So it is a demyelination, diffuse demyelination. The antibodies, they attack the neurons and take away their myelin sheath. So polyneuropathy. Then there is a condition known as AMAN, which is acute motor axonal, very poor prognosis, neuropathy. Then there is a variant which is almost AMAN but with sensory involvement, that is acute motor and sensory axonal neuropathy. Last but not the least is the Miller-Fisher variant. Sorry, Miller-Fisher variant. Can anyone tell me Miller-Fisher variant has what triad?
Ataxia, areflexia, and ophthalmoplegia.
Wonderful. So, ataxia, areflexia, and as I was mentioning, ophthalmoplegia. Oh. Okay. So, what are the symptoms for GBS? Anyone? So, it's a progressive symmetrical ascending limb weakness. So, there is a progressive symmetric ascending kind of weakness. Second is areflexia, sensory symptoms plus minus. Cranial nerve involvements. Which is the most common cranial nerve involved in GBS? facial nerve. Okay. Then is autonomic dysfunction. So patients, they have tachycardia, labile BP, arrhythmias can happen, paralytic ileus can happen, and urinary retention is a very common feature. And the sixth is respiratory failure due to respiratory paralysis. How do you diagnose GBS? Anyone? Is there any criteria to diagnose GBS? Yes, there is. It is known as Brighton's criteria. So there has to be a progressive weakness in more than one limb. There has to be areflexia, and the duration for this has to be less than 4 weeks. Okay, this is Brighton's criteria. And then followed by this, what investigation is the most important investigation is CSF analysis. So what do you see? You see albuminocytological dissociation. So what will you see is proteins will be elevated and cells will be not as much elevated. So proteins are elevated, but the total count is almost okay. Then further on, nerve conduction studies are important. What kind of waves do you see in nerve conduction study in GBS? Prolonged F waves, very important. Prolonged F waves, and you can find conduction blocks here and there. So conduction blocks happen, demyelination leads to conduction block, and there is slow conduction velocity. The worst form of GBS, that is the axonal form, it has amplitude reduction also. Are there any antibodies identified for Guillain-Barré? Anyone? So there are two set of antibodies, anti-GM1 and anti-GQ1B. So GQ1B is for Miller-Fisher variant. Why are these important? They can be asked in the true and false statements. So knowledge can get you some marks. It is not that if you don't know them, you'll lose something. But if you know, there are chances if there are any true and false statement, then you can make a good answer. Okay. So you all are preparing for EDIC exam. So you need to know what are the criteria for ICU admission of GBS. Anyone?
Respiratory compromise.
Okay. So,
and then if they're also having an autonomic dysfunction, yeah.
So, how do you assess the respiratory compromise?
Yeah, you will by clinical monitoring, you will and monitoring, including doing ABG. You know, clinically, by the time you see them having respiratory distress and maybe slowly having a hypercapnia, you know that it's time to support ventilation.
Correct. So that is a very scientific approach. Good. The most commonly used clinical method for assessing a patient of GBS is single breath count. So you tell them to count with you from 1 to 100 in a single breath. And you start counting by yourself also. And then you will see that the patient, if it is single breath count is less than 20, this patient will definitely get intubated. So this shows that the patient has lost the vital capacity. So vital capacity monitoring and bedside PFT, this is bedside PFT. And you need to do it serially. Okay. So this is very, very important for us to know that the patient may have a respiratory paralysis, which is the most common indication for ICU admission. Rest are labile blood pressure, rapidly progressing weakness in less than 24 hours, and of course, people who have bulbar dysfunction, because they will start speaking in nasal twang, and if you do not put a nasogastric tube or intubate them, they will aspirate and they will die. So that is very, very important for us. So what is the treatment? What is the treatment? Number one, it is IVIG or plasmapheresis or both. No steroids. And of course, DVT prophylaxis, very important. Early intubation, very important. Okay. So the answer here is IVIG or plasma exchange. So Guillain-Barré syndrome, immune-mediated polyneuropathy affecting the peripheral nerves. IVIG and plasma exchange, they reduce the severity of disease and improve the recovery time. Steroids are ineffective in typical GBS and they are not recommended. The problem is antibodies, and the treatment is to take away these antibodies with the help of either IVIG, which binds to them, or by plasmapheresis, which cleanses them out. Is that okay? Clear about GBS?
Yeah. Thank you,
Great.
sir.
Great. So now we move on to the next question. A 65-year-old male with atrial fibrillation develops acute left-sided weakness. CT scan shows an ischemic stroke. What is the recommended door to needle time for initiating IV thrombolysis? What is the thrombolysis window? Anyone?
4.5 hours of symptoms.
So it is 4.5 hours. But what is now the patient has come, you have done the CT head to rule out an ICH. Do we do an MRI?
No need, just CT and random blood sugar.
Yes. So MRI brain is not required. Just do a CT head to rule out ICH. And then if the patient is within 4.5 hours, you initiate thrombolysis. But what is the door to needle time?
60 minutes.
Yes. So it is 60 minutes. So the answer is,
Bring my bag.
oh, not the symptom onset, sorry. It is the hospital arrival. So if the patient has come within 4.5 hours, then the door to needle time should be less than 60 minutes. So the ideal is to take the patient to CT room, get a CT, and the moment the patient has completed the CT head, you should be able to start the IV thrombolysis infusion. So the AHA stroke guidelines recommend IV alteplase, which is TPA, recombinant, within 4.5 hours of the symptom onset, but door to needle time should be less than 60 minutes to have the best of the outcomes. A 32-year-old man with refractory status epilepticus has been intubated and now is receiving midazolam infusion. Which of the best is the which of the following is the best next step if the seizures persist? So we've started midazolam. What will you do next?
Anti-platelet therapy. Anti-epileptic therapy.
So we would start either the phenytoin or start the levetiracetam. So this is a patient who has refractory status epilepticus. It requires IV benzodiazepines first, followed by second line drugs, anti-epileptics like phenytoin, levetiracetam, valproate sodium. And if the seizures still persist despite all of this, then the patient may need a phenobarbital coma, or ketamine may be needed to suppress these seizures, because then they are known as super refractory seizures. The patient will need hyperventilation and keto diet also. Which of the following findings is most suggestive of brain death? Okay, so absent deep tendon reflexes, absent corneal reflexes and oculocephalic reflexes, unreactive pupils with minimal spontaneous breathing, and or isoelectric EEG with preserved vestibulo-ocular reflexes. So which of them is the most suggestive of brain death? So the answer is
B.
First of all, the answer is absent corneal and oculocephalic reflexes. But what is brain death? Can you define that for me, anyone? So brain death is basically an irreversible condition in which there is cessation of all cerebral and brainstem. So they are differentiated here. And brainstem functions. So this is very important. Which functions they include? Number one, consciousness. Number two, brainstem reflexes. Number three, spontaneous breathing, that is respiration. Number four, cardiac function is preserved. Okay. So what are the preconditions for diagnosing brain death? Number one, there has to be an irreversible cause of brain death or coma. So we have to understand that the patient developed a cardiac arrest, required a CPR. CPR went on for a long time, and now the patient has revived, but the patient is not coming out of coma. So this is a hypoxic ischemic encephalopathy or coma. Second is absence of hypothermia. You have to make sure that the patient is not hypothermic. You have to make sure that the patient is not hypotensive also. You have to make sure that there are no metabolic problems like ammonia, like calcium, like thyroid disease, or toxic disturbances. They should not be there. The patient should not have been given any neuromuscular paralysis. So patient should not have been given any sedation. The core temperature has to be more than 36 degrees. These are preconditions when you start thinking that this patient may have brain death. And the systolic BP should be more than 100 millimeters of mercury, even if the patient is on vasopressors and the BP is maintained at more than 100. That is when we start thinking about brain death. So what are the main criteria? What are the main things that we assess? Number one, the patient should be E1M1 and V1 or VET, whatever. So this should be the GCS. So this signifies coma. The patient should be in coma. Number two, there should be absent brainstem reflexes. Now we have 6 of them to be mentioned. You can write down. Number one, pupillary reflex. Pupils fixed dilated 4 to 6 mm. no reaction to light. Number B, corneal reflex. Our corneal reflex. Number C, it is oculocephalic reflex. That is also known as doll's eye. So doll's eye should be absent. That is no eye movement with head rotation. Of course, there is there is D, which is cold caloric test. That is oculovestibular reflex. So that is cold caloric test. There should be no eye movement. There should be no eye movement if cold water is put into the ear. That should be absent. Then E is there should be no cough reflex. If the patient has a cough reflex, you can still think that the patient is salvageable, or he or she may not have brain death. Then, of course, lack of facial motor response. Then there is something known as apnea test. What is apnea test? So apnea test is basically the patient should not have any spontaneous breathing effort at the end of 5 to 10 minutes after removing from ventilator. What is the EEG test? Anyone? No EEG activity for more than 30 minutes. If you really want to prove the brain death, get a cerebral angiography. In cerebral angiography, there will be no cerebral blood flow. Nowadays, you can check this with transcranial Doppler. So either absent or reversed diastolic flow. And then there are nuclear brain and all. So we have to keep doing these tests every 6 hours, and then we can diagnose brain death. So which of the following, now that I have told you about it, do absent deep tendon reflexes count anywhere in brain death?
No.
No. Do absent corneal and oculocephalic, that is doll's eye, contribute to diagnosis of brain's death? Yes. Unreactive pupils with minimal spontaneous breathing. There should be no spontaneous breathing. Isoelectric EEG with preserved vestibulo-ocular reflex cannot be with preserved vestibulo-ocular reflex. If they are absent, then it is not, then it is brain death. But if it is absent, if it is present, then it is not a brain death. Okay, I give you a EDIC level question. I need you to interact. So a 45-year-old man with severe TBI after road traffic accident is in your ICU. CT head, it shows extensive cerebral edema. With midline shift. Now, 72 hours have passed and there is no motor response. So GCS is E1, M1, V1. Pupils are 6 mm fixed bilaterally. There are no corneal reflexes, no doll's eye movement. No cuff while suction. His temperature, core temperature is 36.5. His BP is around 110, 120. He is on noradrenaline, low dose. Apnea test, no breath at 10 minutes. And ABG shows a PaCO2 of 68 at the end of 10 minutes. Now, does this patient meet the criteria for brain death?
Yes, it does.
Why? Which are the factors favoring brain death in this patient?
The patient may have reversible cause, so we have to decrease ICP first.
So we will only focus on the factors which can indicate brain death. So the major is that the 72 hours have passed, the patient has no motor response, pupils are fixed dilated, there are no corneal reflexes, no doll's eye, there is no cough effort even during suctioning, and the temperature, the BP, they are within the normal limits and they are not contributing to the coma stage of the patient. We've done an apnea test and it is apnea test. The patient has failed the apnea test. He has not had any spontaneous breath despite good elevation in CO2. So this patient fulfills all the prerequisites for a brain death. Okay? This is how you should describe such a patient. So the answer is absent corneal and oculocephalic reflexes. Brain death requires absent brainstem reflexes, including corneal, oculocephalic, pupillary, cough, and vestibulo-ocular. An isoelectric EEG will support the diagnosis, but presence of vestibulo-ocular reflex, it excludes the brain death. Are we clear on this?
Good afternoon.
Yes.
Hi, before you move on, can I just ask, in your STEM that you've just done with the most criteria being fulfilled, who do we want to know though about sedation, about his electrolytes and stuff? Because he could fulfill all of those, but if he'd been sedated, if his sodium was 160, then we potentially wouldn't have done the test anyway. So do you just assume if it's not given to you on a STEM that it means it's normal?
Yes.
Okay.
As far as the real life case scenarios are concerned, we may think differently. But when it comes to examination scenarios, they will give you all the information that you need, and they may not give you any information that you do not need.
All right. Thank you so much.
Yes. All right. Next question is, which intervention is most effective in reducing ICP, that is intracerebral pressure, in a patient with TBI? So is it mannitol? Is it dexamethasone? Is it fluid restriction? Or is it starting an anti-epileptic drug? So what is the answer?
Mannitol.
Which drug is the most effective? So the answer is mannitol. So the mannitol, it acts by osmotic diuresis. This is basically a question from neuropharmacology. By reducing blood viscosity, improving cerebral perfusion. Dexamethasone is not indicated in traumatic brain injury. It is only indicated in meningitis-related edema and maybe tumor-related perilesional edema. So mannitol stands out as the drug of choice. Which of the following drugs is safest for neuromuscular blockade in a patient with Guillain-Barré syndrome? Is it succinylcholine? Obviously, we were assessing the patient of GBS and the patient is going down on the respiration, the vital capacity is dropping, and we fear that the patient may land up into respiratory arrest. So we want to intubate such a patient. Which is the drug which is the safest for intubating such a patient? Is it succinylcholine? Is it this rocuronium? Is it atracurium? Or is it vecuronium? And why?
I'll go for rocuronium.
Why?
Well, I know it's the safest amongst all the muscle relaxants. It's non-depolarizing blocker, unlike succinylcholine, which I know may give rise to hyperkalemia in these patients with
Wonderful. Wonderful. Very
neurological
good answer.
diseases. Yeah.
Yeah. So succinylcholine has got a problem to lead to life-threatening hyperkalemia. So no doubt it is the fastest acting drug, but at the same time, in a patient of GBS, there are chances that the body tries to upregulate the acetylcholine receptors. So
Yeah.
body upregulates the acetylcholine receptors, and we all know that succinylcholine acts and blocks them, leading to release in potassium in the bloodstream. So it leads to hyperkalemia, and these patients can develop fatal hyperkalemia during that time. All of the depolarizing can do that. So succinylcholine is, broadly speaking, contraindicated in GBS. So the only other drug that remains which is fast acting is rocuronium. It does not cause potassium release, and in case you need to reverse rocuronium, which is the drug which is approved to cause reversal of rocuronium?
Sugammadex.
Yeah.
So it is Sugammadex. So these are the questions that you will keep seeing in the exams. Okay. So the answer here is rocuronium. Oh, succinylcholine is contraindicated in GBS. So due to severe hyperkalemia. Non-depolarizing are safer, and rocuronium being the fastest, it is the preferred drug. Okay. A 50-year-old man with myasthenia gravis, so MG is myasthenia gravis, comes with respiratory distress. ABG shows hypoxia and carbon dioxide retention, that is hypercapnia. What will you do next? Will you do IV steroids, pyridostigmine, IVIG? What will you do next? So patient has type.
Intubation.
Intubate the patient.
So we will intubate the patient, and then we will decide as to what is to be done next. So this is a case of myasthenic crisis, and it causes respiratory failure very fast due to diaphragmatic weakness. Intubation is the priority, followed by IVIG or plasmapheresis. Pyridostigmine has to be stopped to prevent excessive secretions and drooling. Is that clear?
Yeah.
Yeah. So there are certain key takeaways. What is number one? You have to maintain a CPP of 60 to 70 millimeters of mercury and ICP of less than 22 millimeters of mercury in traumatic brain injury. IV thrombolysis, the window is 4.5 hours. The drug is recombinant DPA, and the door to needle time is 60 minutes from entering the hospital in ischemic stroke. IVIG or plasma exchange is the drug of or the treatment of choice for GBS. No steroids in GBS, please. And for SCH vasospasm, which can occur anywhere between 3rd to 13th day, you use nimodipine. Propofol is the sedative drug of choice in neurocritical care for all the obvious reasons, although there is a problem known as propofol infusion syndrome, and it happens when it is given at more than 4 mg per kg per hour for more than 48 hours. Brain death confirmation requires loss of all brainstem reflexes, including corneal, oculocephalic, vestibulo, uh, vestibulo-oculogyric reflexes should be vestibulo-ocular reflex should be absent. Okay, so these are some again comprehensive small tidbits for you, which you will need to remember for a long period of time, even after you've cleared your headache. Cerebral blood flow and autoregulation. First, we did few questions. Now we will just go through the theory part because you already know the theory. I would just brush upon the important key takeaway points, and then we might do some case-based scenarios again. So the cerebral blood flow is maintained at 50 ml per 100 grams of brain per minute. The autoregulation stays between a map of 50 to 150. Whenever the mean arterial pressure decreases, there is vasodilatation to maintain the cerebral blood flow. Whenever the mean arterial pressure increases, there is vasoconstriction to prevent hyperperfusion related cerebral edema. So the nature is great. Whenever the blood flow increases, it causes vasoconstriction. Whenever the blood flow decreases, it causes vasodilatation. The theme is to keep the brain well nourished, well perfused, but not luxury perfusion, so that it may develop cerebral edema. So it is kept in a very tight bracket. This autoregulation of brain or the blood pressure of the brain is impaired in traumatic brain injury, ischemia, even during anesthesia while we are using the volatile agents. The concept of cerebral perfusion pressure comes from the subtraction product of mean arterial pressure and the intracerebral or intracranial pressure. Normal ICP being 5 to 15, we have to maintain a ICP of 20 to 22, and whenever it goes beyond that, we need to give either hyperosmolar medicines, mannitol, 3% saline hypertonic, or sedate the patient. What is the Monro-Kelly doctrine? It says that the skull is a closed cavity, and due to the closed cavity, which cannot expand, if the brain is edematous inside, for example, let us say this is the skull and this is the injured brain and this is the healthy brain. So this is the healthy brain, this is the injured brain, which has no sulci gyri on it. So when it will become edematous, it cannot go towards the skull because skull is fixed. So what it will do is when it develops edema, it expands and compresses the healthier side of the brain, causing midline shift. And in return, what happens is the healthier brain also becomes dysfunctional because of the pressure by the unhealthy brain. This is the Monro-Kelly doctrine. Because the skull is fixed volume, brain, blood, CSF, everything, increase in any one component by edema, hemorrhage, or mass must be compensated by a decrease in the other. So this will shrink in size, CSF flow will decrease, and everything. Important brainstem reflexes. Number one, pupillary reflex is cranial nerve second and third. Brainstem dysfunction is confirmed if it is absent. Corneal reflex is mediated by trigeminal and the facial. So cranial nerve 5 and 7. Its loss suggests severe brain injury. Oculocephalic doll's eye reflex is 3, oculomotor, 6 and 8th, all of them working in tandem. It will be absent in brain's death. Cold caloric, that is vestibulo-ocular reflex, it is mediated by 3rd nerve, 6th nerve, and 8th nerve, the same that carry oculocephalic. No response is brain death. You can take a snapshot of this. I have consolidated it for you. You can take a screenshot for this. These are the brainstem reflexes, and if they are absent collectively, it indicates brain death. Is that okay? Okay. Now comes the traumatic brain injury, synopsis for it. The targets are to maintain the cerebral perfusion pressure of 60 to 70 millimeters of mercury. We should avoid hypotension at all cost. See, if a patient of traumatic brain injury is having a blood pressure of 80 and the resident on duty is not doing anything, it is basically a medical negligence. So we should avoid hypotension in traumatic brain injury at all cost. The blood pressure should remain above 90 systolic, and the patient should never have hypoxia. They may have ARDS, but then you should work towards getting the PO2 levels more than 60 at all point of time. Sometimes you have to enter into a lockjaw situation, because if you increase PEEP, the ICP it increases along with. So you have to maintain a balance to reach the level of PEEP where you start getting PO2 levels more than 60, and also avoiding hypotension. You give IV fluids, you start vasopressors, you try to maintain a blood pressure of more than 90 and oxygen of more than 60 to keep the cerebral perfusion pressure within the range of 60 to 70. ICP control is extremely important. You elevate the head, you sedate the patient, you maintain a normal capnia, keep it between 35 to 40, give either hypertonic saline or mannitol to maintain the cerebral volume as per the Monro-Kelly hypothesis. And if nothing works, then you need to break open this skull so that the brain can swell on this side. It can go on this side. So decompressive craniectomy, craniotomy, so that your Monro-Kelly doctrine, it is broken, and then the brain can go swell out through the opened area and can release the unaffected brain. Strokes, ischemic and hemorrhagic. Ischemic stroke, the management is IV thrombolysis with recombinant TPA within 4.5 hours. The door to needle time is, of course, less than 60 minutes. If you have gone past the 4.5 hours, do a DSA, look for any thrombus within the blood vessels, and then you can do endovascular thrombectomy if the patient has landed up after 6 hours and you can still feel that the patient is salvageable. As far as the hemorrhagic strokes are concerned, tight BP control target of less than 140. Here, there are no targets for blood pressure control. Whatever the BP is, yeah, up to 200, it is fine systolic and should not go beyond 200. But do not aggressively control blood pressure in ischemic stroke. But in hemorrhagic stroke, intensive control is critical for the blood pressure, which has to be kept less than 140 at all times. You can do reverse anticoagulation if the patient has an anticoagulation related bleed, like a the plasma concentrate for warfarin, idarucizumab for dabigatran. So these are the reversal agents. You can give vitamin K for warfarin as well. Then comes subarachnoid hemorrhage. Usually it is due to berry-aneurysms, but can happen traumatically. Most common cause is berry-aneurysm. And the most common problem is vasospasm, which occurs anywhere 3 to 14 days. The treatment is nimodipine. Then comes status epilepticus, seizures for more than 5 minutes. This is number one definition, or more than 2 seizures without recovery. So patient had a seizure, recovered, then had another seizure. This is not status epilepticus. This is seizure that happened. This is status epilepticus. Or seizure kept on happening and continued to happen. This is status epilepticus. First line is benzos, benzodiazepines, lorazepam or midazolam. Second line is IV levetiracetam or phenytoin valproate. These are the anti-epileptic drugs. And if it is a refractory, then you give IV propofol or barbiturate. In super refractory, you give steroids, you give ketamine, you give keto diet, you give all sort of things, so that the patient may have a break in the. Do not paralyze a patient of status epilepticus, because that will only take away the muscular component of it. Brain death criteria, prerequisites. Patient should have a known irreversible cause. There should be no confounders, no sedation, no hypothermia, no metabolic derangements. There should be absent brainstem reflexes, pupillary, corneal, vestibulo-ocular, cough, gag, nothing should be present. Patient apnea test at 10 minutes. The patient should not have any respiratory drive, provided the PaCO2 is more than 60 millimeters of mercury. Coming to neuropharmacology, four drugs very commonly used. Propofol, drug of choice, decreases ICP, fast onset. Yes, there is a risk of propofol infusion syndrome. Dexmedetomidine, it is neutral on ICP, preferred for delirium only because of its sedation. Problem is causing bradycardia and sometimes hypotension. And when you need to stop dexmedetomidine, the patient may have rebound hypertension. Hence, the drug is not preferred in severe TBI, maybe used in mild. Midazolam, it has minimal effect on ICP, but the problem is it can continue to sedate the patient even after its infusion is stopped. Ketamine, very good drug, but it increases the ICP because of the muscular movements and sympathetic stimulation. It can be used in status epilepticus, specifically when the patient is hypotensive and you cannot use propofol or phenobarbital. Osmotic therapy for ICP control, very important. Mannitol is drug of choice at the dose of 0.25 to 1 gram per kg IV. There is a certain risk of hypotension and renal injury. So whenever kidney is also involved, you may not use mannitol. Then hypertonic saline becomes the drug of choice. Sometimes patients do not have intravascular volume. Mannitol will be contraindicated there, but hypertonic saline will be more effective in such condition to be used for anti-cerebral edema measure. Vasopressors in neuro ICU, norepinephrine will always remain the preferred drug to maintain the cerebral perfusion pressure. However, phenylephrine can also be used. It is a pure alpha agonist, but the risk is that it may increase the MAP at the cost of reduction in cardiac output. So the patient may have a renal injury then. Certain conditions, medical conditions, very important from neurocritical point of view. Guillain-Barré syndrome, diagnosed by a short history, less than 48 hours, progressive, symmetrical loss of motor movements with sensory dysfunction, specifically ascending paralysis, areflexia, autonomic dysfunction, ataxia, ophthalmoplegia, all of these things. CSF will show albuminocytological dissociation, elevated proteins but normal total count. Treatment is IVIG or plasmapheresis. Steroids not effective. Bedside PFT, very important test to be done. Antibodies are involved. You need to remove the antibodies. A criteria to shift the patient to ICU are respiratory compromise, PFT, single breath count less than 20. You need to intubate these patients. The drug of choice that you should use is rocuronium. You should not use succinylcholine. It can cause life-threatening hyperkalemia and cardiac arrest. Then myasthenia gravis, we know antibody-mediated neuromuscular junction blockade happens. There is fatigable muscle weakness. The patient in outpatient department may present with ptosis, or in the ICU may depend with respiratory failure in myasthenic crisis. Hydrophonium test is for the clinicians to be done in the OPD with anti-CHR antibodies. But the point is that it is the anti-choline receptor antibodies which are to be taken away. And again, whenever something is antibody mediated, the treatment will remain IVIG or plasma exchange or peridostigmine. Peridostigmine, however, should be stopped when the patient is to be intubated because it increases the secretions. So summary takeaways, again I am repeating because these are the most important takeaways. CPP's MAP minus ICP, target CPP 60 to 70. IV thrombolysis within 4.5 hours, door to needle less than 60. In TBI, avoid hypotension and hypoxia. BP should never be below 90. PaCO2 should never be below 60. Use osmotic therapy for ICP control. Mannitol is drug of choice. 3% saline, specifically if the patient is hypovolemic or has a renal dysfunction. SAH 85% cause is barianeurysm rupture. Nimodipine is given for vasospasm, which happens between 3 to 14 days. Neuro-ICU sedation, propofol is preferred. Midazolam accumulates. Pris is something to be looked for. Status epilepticus, start with benzodiazepines, move up to AEDs, propofol, phenobarbital. These are the ways, and then ketamine will follow. In GBS, IVIG, plasmapheresis, steroids not indicated. Do not use succinylcholine. Are we ready for some interactive session? If everybody, you turn your mics on if you want to reply. So a 45-year-old woman with myasthenia gravis presents with dyspnea and ptosis. Dyspnea and ptosis. So this basically is myasthenia crisis. ABG shows PSCO2 of 60 and PO2 of 50. What is your immediate management priority?
Immediate intubation
Intubation.
and
And then
medications
we
should be
should
stopped, all the antibiotics,
stop the neostigmine.
and end the
Um,
antibiotic also.
What about, so what is your immediate management priority? Is number one.
intubate the patient.
So yeah, so we should in examination we should say airway protection.
Okay.
Okay, so we would like to protect the airway. How? We would like to put a endotracheal tube. That is the safest way of doing the airway protection. And of course, having a nasogastric tube along with. You should use a non-depolarizing neuromuscular receptor blocker like rocuronium, no succinylcholine. This is the immediate management priority. Which medications should be withheld temporarily? So pyridostigmine is temporarily withheld. Pyridostigmine should be temporarily discontinued. Later on, it can be started again. Initially, it will, because of increasing the secretions and leading to respiratory worsening. So what are the long-term therapies considered for recurrent crisis? If the patient is having recurrent crisis, this patient should be put on at least 5 days of regular plasmapheresis or IVIG, and later on after 1 week when they're extubated, yeah,
Thymometry as well.
they should be on steroids plus azathioprine, or they can also be taken up for CD20 antibody, which is rituximab. Okay, so that is the long-term therapy. These are basically Viva questions. So what are the takeaway points?
Sorry, before you go on to the takeaway point, the patient with recurrent crisis, should we not in the long term also consider doing a thymectomy on them?
See, number one is not everybody has a thymus tumor in them. Not everybody's thymus is enlarged. Yes, in patients in whom thymus is enlarged, they would already have a diagnosis of myasthenia gravis with a thymoma. So whenever you have a patient of myasthenic crisis, they usually, if you look at the case, it is 45-year-old woman with myasthenia gravis. So she already has a history. That is, again, I'm telling, if they do not want you to know that the patient has a thymoma, they will not tell you the patient has a thymoma.
All right,
yes,
thank you.
if they do want to put you through a thought process that yes, thymectomy will help, then they will give you a question that a 45-year-old woman with myasthenia gravis and a thymus tumor is presenting with recurrent myasthenic crisis since last 3 months. She has had 3 cycles of plasmapheresis, and every time she lands up in the emergency, she requires intubation and is ventilated every time. What is the next best decision for this patient that you might want to take? Then the answer will be, I would prefer getting the thymectomy done. Because the patient has come 3 times in the ER with a similar myasthenic crisis, And obviously, a patient who is a known patient of myasthenia gravis will be on regular medication. And if she is failing the medication, that means she is a refractory myasthenia gravis patient, then definitely, yes, I would prefer getting a thymectomy done, but then it will be given in the question stem only.
All right.
All
And
right.
before you move on, sorry, I'm gonna just step in a bit. In terms of the dosing of the neuromuscular blockage, I'm aware that there is a change in how you dose it. I just don't quite remember what it is. But I'm aware that it changes because of the duration, or I'm not sure.
As
We
for
don't
the
give
rocuronium
we
dosage,
don't give the regular dosing. I don't know whether it's a half or double in this scenario. So
in myasthenia,
I'm not sure. I'm asking. I know between GBS and the myasthenia, one of them, that the dosing of the neuromuscular blockage actually changes.
yeah. So basically, in GBS, the dose will not change because obviously you are intubating a patient who does not have a neuromuscular blockage problem.
Yes.
Yes, but when it comes to this myasthenia gravis, so there are already reduced number of neuromuscular junction receptors that are available to you. So you may actually give a small dose of the reduced dose of rocuronium, but the problem is that it will take a longer time to act in case of a myasthenia gravis because of the lesser number of receptors available. Are you getting me?
Yes.
Yeah, because it is an all or none phenomena with these agents. If you give the drug, it has to show its effect on all the receptors. So now only few receptors are available, and whatever few receptors are available, you have given the drug. Okay. So in patients of myasthenia gravis, it is indicated and recommended to use 50% of the dose of rocuronium, half.
Thank you so much.
All right. So half dose will be given for the patients of myasthenia gravis. Is that clear?
Yes, it is. Thank you so much.
Great. So take home points are respiratory compromise in myasthenia gravis. So very valid point that you made there is. So if you are using rocuronium to intubate myasthenia patient, the dose will be 50%, 50, half. But in Guillain-Barré, it will be normal. Okay. All right. So we actually come to Guillain-Barré. A 28-year-old man presents with progressive ascending weakness for 3 days. He has areflexia and bilateral facial weakness. So which is the most common facial? I've already answered. Facial nerve is the most common nerve. He has dysautonomy and BP fluctuations. What diagnostic test confirms the diagnosis? So basically question is, how will you diagnose GBS? So one is CSF analysis, the second is
Nerve
nerve
conduction
conduction study.
studies.
Yeah. So CSF will show albuminocytological dissociation. Nerve conduction study will show F wave and Lloyd amplitude. So that is what you will see. It may show axonal pattern of demyelination. What is the first line treatment in GBS?
IVG and
So
plasmapheresis.
Plasmapheresis. What complications should you be looking for in the ICU? Respiratory failure,
Yeah.
blood pressure lability, that is hypotension or
Autonomic
shock.
dysfunction.
Yes, and arrhythmias because of autonomic dysfunction. And delayed DVT with pulmonary embolism,
Hmm.
thromboembolism.
And
Okay.
also pressure sores from immobility if you don't do the right thing.
Yes, correct. So diagnostic test will be lumbar puncture and nerve conduction. First line will be IVIG. Steroids are not effective. ICU monitoring for respiratory failure. Monitor functional vital capacity. Intubate if FVC is less than 15 ml per kg. Autonomic dysfunction, BP lability, arrhythmias, and DVT and venous thromboembolism. So dysautonomia.
We also talked about bulbar bulbar dysfunction, swallowing, and so on in ICU.
Say again?
No, we also mentioned about the third issue to look out for in ICU is the bulbar
Yes,
dysfunction,
bulbar
which will
dysfunction.
lead to
Correct.
aspiration as well
Correct.
as inability
Correct.
to swallow.
Yes. So we would look for bulbar dysfunction also. Very good. Okay. Intracranial hypertension post SAH. So a 54-year-old woman in ICU post aneurysmal SAH becomes acutely confused. So this patient has fifth day with right dilated pupil. Her ICP is 28 and MAP is 100. So ICP is above 22. Cause of concern. What is the potential cause of a deterioration?
Yes, cerebral vasospasm.
Rebleed.
Is it replayed?
So one answer is vasospasm, second is rebleed. Both answers are correct. Anything else?
And delayed cerebral ischemia could be part.
That is
It's too
vasospasm.
early. 5 days.
So
Okay.
it was an SAH. So there are chances that the patient may have had an IVH. So hydrocephalus can also happen on day 5. Okay. So vasospasm, rebleed, and because the mean arterial pressure is still very high, 100 of mean arterial pressure, this patient can bleed any moment. So what are the potential causes? Vasospasm, rebleeding, and hydrocephalus. So what immediate intervention will you do? So immediate intervention will be number 1.
Repeat CT scan.
Okay.
Yes. So a repeat CT head to rule out a rebleed, plus to define
Monitor.
hydrocephalus.
Yes.
Second is to do a transcranial Doppler. Transcranial Doppler. And
osmotic diuresis with a monitor.
Yes. In good centers, you can do a cerebral angiogram also. The moment you've done that, you start 3% saline or mannitol along with. There is no harm in giving 1 dose before doing all of this. Elevate the head end by 30 degrees. You may need to intubate and hyperventilate this patient. And of course, if it is a hydrocephalus, you might need to do a VP shunt or maybe external ventricular drainage. For vasospasm, you can start nimodipine infusion. So all of them can be covered by repeating number 1, a CT head, doing a transcranial Doppler vis-a-vis a cerebral angiogram, giving mannitol and osmotic diuresis, doing a VP shunting or external ventricular drainage for hydrocephalus, for rebleeding, trying to bring down the blood pressure aggressively with labetalol. For vasospasm, nimodipine is the drug of choice. Is that clear?
Yeah.
Any long-term strategy to prevent rebleeding? So then, once the patient is stabilized, you would like to either do a coiling procedure or you would like to do a, I don't know what it's known as, clip. So yeah, clipping. So clipping plus nimodipine to be continued at least for 1 month. Is that okay? That's the long-term strategy. So potential causes for this patient: vasospasm, hydrocephalus, and rebleeding. Immediate interventions are actually elevating, giving hyperosmolar is fine, but getting a CT head is paramount. Consider ventriculostomy if hydrocephalus is present, but that you will diagnose with CT head only. Long-term strategy is secure an aneurysm via coiling or clipping and nimodipine to reduce vasospasm risk. Okay. There used to be some 5H for preventing vasospasm. Can anyone tell me?
We didn't get the question.
What was the question? Sorry.
Okay. What is the triple H?
Sure. It
triple.
was hypertension, hypervolemia. Can't remember the third one.
So one is
But
that
it's
we should maintain hypertension, maintain good
mhm.
BP, but not so high that it bleeds again. Hypervolemia, you should never have hypovolemia for these patients. And third H is hemodilution. So you should keep the blood viscosity low so that the blood flow is going well through the constricted blood vessels. So this is the triple H therapy for vasospasm. Okay, that's a traditional therapy. Is that fine? I just thought of letting you know this.
That's fine, but do we still use that? So have we not moved away from the triple H therapy?
Say again.
Have we not moved away from the triple therapy and rather went for the nimodipine for 21 days?
Yeah, so that is what I'm saying, that
Okay.
hypertension is there, but not as much that we would have a rebleed. So
Okay.
so again, now we will have a quick fast round, some 7-10 questions for you, which were not discussed earlier. A 45-year-old patient with traumatic brain injury has an ICP of 25 despite head elevation and sedation. So what is the next best step? No steroids, hyperventilation won't help, IV Lasix is not indicated. So the only drug that you can give is hyperosmolar diuretic. Mannitol is the drug of choice. Okay.
So your screen is not visible for some
Oh,
reason.
yeah, it stopped. Let me bring it up again. Yeah, can you see now?
Yes, it's
Yes.
come up. Thank you. Yes,
Yes, we
thanks.
can.
So a 45-year-old man with a traumatic brain injury has an ICP of 25 millimeters mercury despite elevation of the head and sedation. So what is the next best step? Quickly, it is like fastest finger first. Somebody has to keep the finger on the answer.
Mannitol.
Let's say
Mannitol.
mannitol. Yeah.
Correct. So it's the mannitol. A 60-year-old patient presents with acute left hemiparesis for 2 hours. CT scan shows no hemorrhage. BP is 190 by 105 millimeters of mercury. What is the next best step?
C IVI. Oh, wait.
Option
So
D.
these are the questions where
IV thrombolysis.
C thrombolysis.
IV
I would
thrombolysis.
definitely, but would you thrombolize at 190 by 105?
No, sir. Option D. Blood pressure should be less than 185 over 110.
Perfect. So we need to bring the BP less than 180 by 100.
Oh yes,
Okay.
first.
So we would give IV labetalol to first reduce the blood pressure and then give the thrombolysis. Okay. Very important question. So don't get carried away to rush, because otherwise this patient will bleed to death. Which brainstem reflex remains intact in a patient with brain death? Pupillary, corneal, or oculocephalic reflex? Or none?
None.
None is the
No,
only
no,
answer.
no.
So we've discussed all of them, but just few points again. ICP monitoring, intraventricular catheters are gold standard for ICP monitoring, and they also allow for drainage of CSF. Number 2, brain death testing requires core temperature to be more than 36 degrees centigrade. The BP should be normal and there should be no confounders. Post-stroke BP management is mandatory to have BP less than 185 by 110. Before TPA, it has to be less than 180 by 105 after TPA. If it is more, the patient is likely to bleed. And let me tell you, they bleed to death. That is all. Neurotrauma, avoid hyperventilation. You do not want to get the CO2 levels below 35 unless impending herniation is there. Vasospasm post SAH, continue nimodipine for 21 days. Important. Okay. So this is just the repeat telecast of everything that we've done. Yeah. A 40-year-old male post-road traffic accident has a GCS of E1, V2, M3. ICP is 28, despite sedation and CSF drainage. Pupils are unequal. BP is 150/90. Heart rate is 48. Bradycardia is already there. What is the most concerning sign here? So the most concerning sign is
severe bradycardia.
bradycardia and anisocoria. Anisocoria means pupillary asymmetry. It is most concerning sign. Bradycardia will tell you that ICP is elevated. Pupillary asymmetry will tell you that patient is going to herniate any moment. So pupillary asymmetry that is given here, pupils are unequal. This is the most important point to be picked up in this question. So what is your next immediate step? Hyperventilate the patient to 32 to 35 millimeters. Why? Because this is impending herniation. So you can hyperventilate the patient more and immediately take the patient for surgery. What kind of surgery? Usually it is just decompressive craniotomy, and if there is a bleed, you can take out the bleed. What is the long-term plan? Decompressive craniotomy if the ICP remains elevated. So take-home point is hyperventilation, although we do not want that, but maybe used as a temporary measure as a bridge to surgery if the patient has a pupillary anisocoria. Okay, prolonged hypocapnia will definitely cause more ischemia and more damage. A 70-year-old woman with sudden right hemiparesis and aphasia arrives 3 hours post-onset. CT head shows no bleed, so you have 1.5 hours more still. The BP is 180/105. Can she receive thrombolysis? Correct. Yes, she still is within the 4.5 hours window. Should we lower the BP before TPA? Yes, we should try to bring down the BP to less than 185/110 with labetalol or nicardipine. Although this patient's BP is 180/105, to gain some leverage, we can still decrease the BP before thrombolysis. What are the post-TPA key risks? So intracerebral hemorrhage can happen. So you need to aggressively monitor the blood pressure and pupillary status or neurological status very, very aggressively. Door to needle time is 60 minutes and below. A 53-year-old woman with 6th post-SAH day, subarachnoid hemorrhage, becomes acutely drowsy. BP is 160/90. Pupils are equal and reactive. Motor exam shows new left hemiparesis. So most likely right cerebral hemisphere vasospasm is happening. Likely cause is vasospasm because there is a new onset motor deficit. Initial investigation will be transcranial Doppler to assess vasospasm. What is the management? Historically, triple H therapy, now euvolemia and nimodipine. Is that clear? It answers your earlier question also, right?
Yes.
Great. So nimodipine given 6-hourly for 21 days is standard of care. Myasthenia. A 48-year-old woman with known myasthenia gravis presents with respiratory distress, PSU2 of 60. Functional vital capacity is 11 ml, less than 20. So what is the next best step? Intubation and ventilation using rocuronium at 50% dose. Medication to hold, pyridostigmine to reduce airway secretions. Acute treatment, IVIG, plasmapheresis, and ventilation, of course. IVIG works faster than steroids for myasthenia gravis, hence should be preferred and reduces crisis duration. Steroids can sometimes worsen the crisis. Okay, same question, mannitol. Yeah. A 69-year-old man comes with sudden left hemiplegia for 5 hours. 5 hours. 5 hours. CT shows no hemorrhage. BP is 195/110. NIHSS scale score is 10. What is the next best step? I just changed the question. What will you do now? Outside the window? Everybody here?
Administer aspirin and admit to stroke unit. C.
Yes, correct. So you will take a conservative call here. Administer aspirin and admit to stroke unit. He is 69. Now let me tell you, if the patient is 39 years, then what will you do? He's
Do you not
5
do a
hours.
DSA? DSA, see if there's a clot and do intra-arterial thrombolysis.
Yes, very good, correct. So if is a young patient and important life at stake, then we would take the patient for a DSA, and then if you can find a intravascular clot, go for intra-arterial thrombolysis, or even what do you call it, thrombectomy.
Endovascular thrombectomy.
Endovascular, yes. Okay. Yeah, a 55-year-old man post SAH, day 4, suddenly develops confusion and left-sided weakness. BP is 155/90. What is the next best step? So, what we will do? Left-sided weakness. So this patient has a obvious neuromuscular deficit, and transcranial Doppler is not in the options. So we would like to do a repeat. No, we would like to repeat the CT head. We discussed this question very early. We would do a CT head to distinguish between rebleed. This patient may have had a rebleed. So BP is still high, no? 155/90. So this patient may have had a rebleed. So immediately you will have to do a CT head to distinguish between rebleed and vasospasm. Yeah, if it is vasospasm, go for nimodipine, no problem. Okay. Yeah, that brings us to the end of this class. Thank you very much. I hope the class was informative for you, and it will help you gather all the thoughts because you're already studying. So it will only help you for getting better.
Sir, can I just ask a question?
Yeah, go ahead.
You know, with the treatment for the myasthenia crisis, if you gave let's say the sequence of treatment with the IVI immunoglobulins, if it doesn't, do you give it time to work? If it doesn't work, then you start plasma exchange, or
Yes.
is okay, all right.
Yeah. So that is why I keep saying either plasmapheresis or IVIG or both.
Okay, all right.
That is why I keep saying, because that is very important. So in many centers worldwide, plasmapheresis is performed earlier than
IVIG.
IVIG. I'll give you a reason why. At least in my hospital, we have done like more of plasmapheresis, lesser of IVIG because of the cost constraints. IVIG is very expensive, very, very expensive. And a plasma exchange is like almost half the cost. So that also helps. And then in IVIG, you have to rely on the kidneys to get the this immune complex to be removed from the body. Whereas in plasmapheresis, the machine of the plasmapheresis is all doing that job also. Because
thank you so much, sir.
With plasma, we are giving only IVIG only, no? So they will bind and remove that complex, the antibody complex also. Yep. Any other question?
Thank you so much.
Yeah.
Thank you.
Okay. Thank you
Yes.
for a patient listening and contributing.
Last question, please.
Yes.
In case of supratentorial hemorrhage, recently in neurocritical care, they submitted that target PCO2 is about 30 to 35 in case of supratentorial hemorrhage. In case of infratentorial hemorrhage, the target PCO2 is 26 for limited period of time. Thank you.
Yeah, for limited period of time, because otherwise what it will do is
For supratentorial
it
and
was
infratentorial, they just divided the target PCO2 in case of
yeah.
hemorrhagic stroke.
So normocapnia is very important for supratentorial hemorrhage, because if you don't do that, it is crucial. It will influence the cerebral blood flow, and definitely it will elevate the intracranial pressure. So I'll have to check, but evidently it is like we have to just keep it around 30 to 35 millimeters of mercury.
Thank you. Thank you.
Thank you everyone.
Thank
Bye
you,
bye.
sir. Thank you, everyone present.
Thank you,
It was a
sir.
really nice class.